Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center.
And I'm Dr. Sean Coomer, Chief Medical Officer of the Kansas City Division and Senior Vice President of Perioperative and Procedural Services. We called this news conference in response to a surge in flu cases in the metro that is having an impact on hospitals across the region and the country, including ours.
During this conference, we'll explain what's happening, how it is impacting healthcare and hospitals, and what we need the public to do. Then reporters will be given an opportunity to ask questions over the next few minutes. Jessica Lovell is watching the chat threads on Facebook and YouTube, or you can ask them directly to me when I call on you if you're joining by Teams. Media, please say your name and the news organization you represent.
We also understand some viewers have tuned in to watch All Things Heart. That scheduled episode will air following this live stream. If community members have questions, please put them in the chat thread. Jessica will watch for those as well.
Please understand that after this news conference, there will be no further opportunities for comment to media. We'll be busy taking care of patients and making sure we're doing the right thing. If we need to alert the public again, we will reach out to media for your help. All right, here we go again. I'm reminded of that song, Here We Go Again. I guess I shouldn't sing. Well, let's get to it. We're going to start with Dr. Dana Hawkinson, Hawkeye, Medical Director of Infection Prevention and Control here at the University of Kansas Health System. He joins us live at the Olathe Hospital where he is seeing patients. Hawkeye, dude, this is another, we're dancing again. It's like deja vu all over. I guess that's the same thing. This is reminiscent of our live streams we did back during the pandemic. We've learned a lot. We're not all huddled around one phone. The impact of this year's flu virus, though, is similar on clinics and hospitals. The big difference with this flu season is it's happening earlier. The infection rate, it's high.
Yeah, I think you're exactly right. You know, unfortunately, even the southern hemisphere right now, Australia is still seeing a surge, even though they're kind of getting out of their influenza season. We are kind of smack dab in the middle of our influenza season. Now, we do have a graph that shows the surge in influenza-like illness, which means people are having symptoms of cough and cold, which could be runny nose, fever, body aches, cough. This is influenza-like illness, and then these people are feeling these symptoms, and this is what we're seeing on this graph. So they're going to an emergency department or an urgent care clinic for evaluation. And what we have in this graph as well is you can see the horizontal bar, the dotted line, that is the epidemic level. So we've certainly crossed that epidemic level. But now if you can also see that surging red line with no curve or no peak, that is where we currently are. The other two lines, however, are from the last 2 years. So you can see that it is similar in the way the curve is trending up, where people are going to the doctor at a certain period of time, and at the bottom of the graph is where we have the weeks of the year. So really in the last couple weeks of the year into this first couple weeks of the year, for the last couple years, we have seen a significant increase or surge in people going to the doctor to get evaluated. Unfortunately, Steve, what we're seeing now and what you just talked about is that that peak has not happened yet. And if you look at the CDC, they are still expecting a few more weeks of this surge of people being ill. Now, again, this is influenza-like illness, so you have to go to the doctor or you have to test at home to see exactly what you have. Obviously, we have to be also concerned about COVID, although those activities are low right now. RSV, but also those other common cold viruses which are circulating. But right now, the significant impact, just as you have said, is influenza. And so what we are seeing now is a continued increase. And again, this is data from a week ago. So it is a little bit older. We know that community activity of influenza virus is surging. We know people who've had influenza. Obviously, just as you said, our patients are coming to the hospital with it as well. What this graph shows, however, is that there continues to be a surge, continues to be high community activity around the nation, but specifically also we're talking about our community as well, that continues to go on. We don't know when it will end. Hopefully it will start to die off or decrease in the next couple of weeks, but right now, especially as kids are going back to school from winter break, we have to anticipate it's going to continue to surge.
say, Hawkeye, the slope of that curve, that curve that's incomplete, it's kind of still going up. And I know we're going to talk a little bit about the different viruses and the different strains of virus, et cetera. But that's a curve I don't like because both of its exponential rise, which is faster than the other years, but also it's already above any other year and it's not done rising. And that point that Australia has another flu surge right now in the middle of their summer, yeah, I don't like that either. And we'll connect those dots in just a bit. Now, you had some other graphs that you've been showing us the last few days that look at some of that. Do you have some others you would like to take a look at now? Or is that going to be later?
Yeah, we certainly do. It can be now or later. We have that pulled up. It's just mostly the most up-to-date data because even our data that we have for our health system is typically a week late because we gather it. Our infection prevention nurses gather it, provide it. But this is the most up-to-date information that we have as of yesterday. And what it basically shows is just our influenza admissions. Now, again, we do it week by week. So even 2.5 days in to this week, we are seeing at 39th campus 23 adults with influenza who are admitted to the hospital, with 3 in the ICU. Here at Olathe and Paola, we have 13 adults with 1 in the ICU, and you can see those other numbers. If we look back at previous weeks, we will also unfortunately see, just as we have said, just to give people a sense of where we have been the last couple weeks, there was a really low amount of influenza admissions, and this is what this graph is showing in the orange. This is for the main campus, Indian Creek, and then our mental health care centers as well. This is not cumulative. This is week by week, so you can see a significant amount of influenza admissions have occurred the last 2 weeks. And again, we're only 2.5 days into this, so we do expect more as well. But that was a huge jump. And just as you said, with the slope of that curve, we can see this in real time here with real people having real illness needing to go to the hospital, as evidenced by the admissions.
Right. It's across the country, Hawkeye, and what we know is with that, it's not just something that's happening here. In addition, there's some other things. There's a stomach bug out there in the community that we're going to talk about, but in just a moment. Now, Hawkeye, is there something that's a little different about this strain of the flu? I know the predominant strain is type A. We call it H3N2 or H2N3, whichever one. And now there's this variant that's got a special name. And talk to us a little bit about that.
Yeah, it's been called a super flu. It's a subvariant K. The important thing to know is we should break it down. So every spring, the influenza vaccine virus strains are determined. Now, there had been 4 in the past for the last couple of years. There's only been 3 virus strains in the influenza vaccine. That is 2 A strains, so influenza A, H1, and an influenza A, H3. There's also an influenza B strain in the vaccine. Now, we should note that influenza viruses are notorious for being able to shift and change the way they look to help evade the immune system. Unfortunately, the match for the vaccine and this current H3 strain of influenza virus is not a good match. Now, you will get partial protection, but it is not optimal, and so that could certainly be aiding in more people having more illness, even if they were vaccinated. But even if you were vaccinated, you are getting partial protection. Your risk of severe disease still decreases. Your risk of going to the hospital still decreases, even if you receive this vaccine this year. And we should note that right now, it does not seem that this current variant is causing any more severe disease than a typical influenza infection does. But we couple that also with, unfortunately, as we have seen, low vaccine uptake in all across the board, whether it's pediatrics, adults, even those with higher risk comorbidities that put them at risk of greater disease as well. So, yeah, it is a new variant, one that wasn't expected. Doesn't seem to be causing more severe disease, but is certainly running its way through the community, and we are feeling it as a community. We are feeling it as healthcare providers as well. Hopefully, again, the activity will decrease, but right now I think we're right in the middle of it.
Yeah, and I think that this new strain covers about 80% of the strains that are active, so it's by far the dominant strain. And as I understand it, Hawk, the normal, if you really got good activity with the influenza vaccine, that's about a 70 to 80% reduction in the chance of severe illness and hospitalization. This one, with this particular strain, runs about a 50% reduction. So to your point, vaccination still works. Maybe not quite as well, but it's still one of your best lines of defense. And despite all the fake news out there, the vaccines are still incredibly safe, and especially the influenza one has been around for years and years. Thoughts?
Yeah, absolutely.
Yep. And so
I think you're exactly right. Yeah, we would like more uptake. The vaccines are completely safe. They are not meant to protect you from infection. What the vaccines are meant to do was decrease your chance of getting severely ill, decrease your chance of going to the hospital, the ICU, and of course, decrease your chance of dying as well. The vaccine continues to do that, even though it's not the best match this year. It will help boost that immune response after vaccination to get ready to see if you see the infection and are infected, you will have that immune response there to help reduce the risk of those complications that we talked about.
Yeah, and I think that's a really darn big deal. Let's hit what some of those symptoms are like, though, and distinguish this a little, Hawkeye, from the stomach flu. Because some people, we use that term stomach flu, and it's really wrong. It's a stomach bug, but it's influenza that we're talking about, which was really predominantly a respiratory disease. Talk to us about that.
Yeah, you are exactly right there. So starting with influenza, the most common symptoms, just as you said, are more of a respiratory type symptoms. So you're going to have the systemic body symptoms of the fever, chills. You're going to have the body aches. A lot of people will say they feel like they've been hit by a truck or a train. And then you'll have some localized symptoms as well, most notably respiratory tract symptoms, cough, sore throat, maybe some runny nose, headache. And then occasionally you can also get some vomiting and diarrhea, but that is not the vast majority of the issue. The vast majority of this infection and its disease is the respiratory type symptoms. And just as you said, yeah, unfortunately there's also a stomach bug going around. That is most likely norovirus, and that unfortunately spreads very easy through households, through schools, through daycare centers, and other places like that. That is, again, predominantly nausea, vomiting, feeling bad, and that usually or typically goes away in 48 to 72 hours.
You know, Hawkeye, we've talked about the pillars of infection control before, maybe about something called COVID, and I think it still applies now. So let's hit those again, because we know those pillars keep us safe every day, even into this moment and going forward in the future. Let's hit them. Yeah,
I'm going to say the first thing is be prepared, be up to date with your vaccines. Right now, it continues to be up to date with your COVID vaccine for this year. Be up to date with your influenza vaccine. If you haven't gotten influenza, there is still time to get influenza vaccine. It does take 7, 10, 14 days to start to mount that immune response, but we still have a long way to go in influenza season, and other variants or other types can come through as well. That is vitally important. Be up to date with your vaccine. We also know that whooping cough or pertussis is going around nationally. So it is vitally important to understand, get your tetanus vaccine, which has a component of that in it as well. We as adults are not immune to that, so we get it and spread it on to those kids. So be up to date with the vaccines. The next most important thing, and this is for everybody, is adequate hand hygiene with either alcohol hand sanitizer or soap and water. Frequent hand washing or hand sanitization is vitally important, especially out in the community. Why? Because a lot of people may not be in a space where somebody is actively sneezing or coughing, but when those people are ill and they are out in the community, those virus particles will tend to drop onto those high-touch surfaces like handrails, like door handles, like church pews. As we touch those surfaces, we can then touch our face, our eyes, our nose, our mouth, just as I had gave an example of. We do that frequently throughout the day. We do it many times. That is how we can inoculate ourselves with these viruses and then develop the illness. So trying to avoid those things when you are out in public, but also doing frequent, adequate hand sanitization is going to help keep you safe and reduce your risk of infection. The other thing you can do, is we've always advocated for this, is wear a well-fitting mask. This will help reduce your chance of getting infection, even if you are in spaces where people are not wearing masks as well. If we do those things, we can reduce our chance of getting infected with these viruses and keep everybody safe, keep our households safe.
The crux of this news conference, because we're asking and telling people what we need to do to help stop the spread of the flu, both for patients' own benefit as well as the benefit for those in healthcare. In just a moment, I'm going to turn to my partner, Dr. Coomer, and have him describe some of the challenges we're facing in the hospital again that unfortunately are a little reminiscent of COVID at some of its peaks. And we're seeing those numbers come to us again because of this influenza crisis that we face. And so there are things we know that we're going to need to do. So Hawkeye, a couple of things that are a little different about influenza. You tend not to spread it until you get sick. Now, COVID, you could spread for a couple of days before you got sick, which made kind of that universal masking really important. Influenza, it's more when you're sick, and maybe just a little before and a little while afterwards. So we have a little bit of an. This is a little better, because when we know we're starting to get sick, you can really help folks by staying home and putting on a mask if you have to go out in public.
Yeah, that's exactly right. If you are ill, please stay home. I know it is very difficult practically if you have work and school and all of those things. But just as you said, with COVID, you were able to spread that disease to other people up to 4 days prior to even developing any symptoms. With influenza, it's really when you are symptomatic. And really what we would like you to do and prefer you to do is stay home until you are fever-free without any medications for 24 hours. At that point in time, your ability to spread that disease to other people is much less. So that is vitally important as well as we are out in the community. And again, it is difficult. We know that there are real world problems, bills to pay, work to get to, school, all of those things. We are just trying to give that message and the recommendations to help keep everybody in the households, especially those high-risk people, and our community safe.
Yeah, this is certainly not a stay-at-home or closed businesses or universal. We're not talking about that.
No.
We're just trying to help you stay safe and to keep your loved ones safe around you, so that we don't have the kind of outbreak that could really even make things a lot harder. And remember, there are a lot of vulnerable folks out there who, because we know the people who get the sickest with the influenza are just like COVID. People who are older, people who are younger, people with other healthcare problems, cancer, transplant, and other chronic health conditions, diabetes, asthma, etc. Those are the folks who are going to struggle if they get a bad case of influenza, and especially with this vaccine not working quite as well, although still beneficial, still something you want to do. Let's frame this a little bit now about what's going on here at the University of Kansas. So, Dr. Coomer, I know that you and I have been involved in some pretty important calls the last few hours and yesterday afternoon. Give us a sense of where we are in the hospital and some of the actions we're having to take.
Yeah, the challenges that we have as a health system are really operationally, right? We have a significant number of folks waiting for beds in the ER. We have a record census. So there's not places for people to go. And then we add on elective cases. So what we're doing now is we are starting to postpone some of those cases, OR and procedural cases, that require an inpatient stay, if they can be pushed off, and then prioritize some of the outpatient things that we can get people out and continue our book of business. But there's really two sides to this, right? So operationally, yes, that's about the patients getting to a room, but if you remember in COVID, we had those difficulties, but the next difficulty that happened is our staff started getting sick. So what we've asked our staff, and we're requiring them in our clinical areas, whether it's ambulatory, OR, anywhere in the hospital, is to wear a mask while they're here and around patients. That's going to be imperative. I've talked around town. There are some of the other chief medical officers in regional hospitals. They're having some difficulties with their census as well. They're seeing the same kind of viral illness and spikes and so forth. Some of them have had to postpone their cases starting yesterday. Some have actually artificially postpone their cases. Their patients are showing up sick. So you don't want to get, have an elective operation while you're sick because you have bad outcomes. So there's two sides to this. It's about the patient and it's about the people taking care of the patient. And so that's what we're kind of, working through right now.
And I think masking in our inpatient wards or in the clinic by our staff helps protect patients in case we're starting to get sick, or people think, oh, I've just got a mild cold, and they're working, and so just wear a mask. Let's get through this together. We're hoping this isn't going to last a terribly long time, but we are doing that. And as to your point, we had to delay some cases. If you are sick, we still want you to come to the emergency room. Those EDs may be busy. We want you here. And the reason is, if you start getting more short of breath, if you feel like you can't keep up with hydration because you're so overwhelmed by the illness, which can easily happen in influenza, if you have an underlying disease like diabetes, emphysema, heart failure, asthma, cancer, transplant, we can go on down that list. If you feel like that disease is beginning to get out of control, don't sit at home. Get to your providers, get to the emergency room, let people know that you're having a problem, and let us help get you into the right place. If you have a clinic appointment scheduled and you are worried about coming in, calling ahead to your provider and have a conversation to see if telehealth is appropriate. We're increasing our telehealth visits and our capacity once again so that people don't have to feel worried that they're going to come in and get sick while they're here. If you do need to drive in, we encourage you as a patient to follow the pillars of infection prevention and control. Hawkeye, you went through them, but wear a mask, wash your hands, get vaccinated, keep your distance, and if you are sick, definitely put on that mask and try to go out. So anything else you would want to add to that, sir?
Yeah, absolutely. Those are all things we should all be doing. They're very easy. They're very simple. They will help save you from being more ill than you would have been if you didn't do those things. So again, protecting you from infection, certainly a mask if you don't feel comfortable out in the community, that will help reduce your risk of infection. The hand hygiene, adequate, frequent hand hygiene. Avoid putting your hands in your eyes, your nose, your mouth when you're out in the community. When you're doing all of those things, that will help avoid infection. If you do get infection or exposure to the virus, that vaccine and that immune response that has been developed because of the vaccine is going to help reduce your chance of severe illness. And then the other thing is test early and test often. So there are home tests that you can get that test for both influenza A and influenza B, but also COVID, all in one test. You know, if you're driving home tonight, maybe pick up a couple of those if you can. And then if you do have illness or symptoms, it is reasonable to then test while at home so that you can get the earliest knowledge of the infection as you can, and then certainly call your physician to get treated. We do have antivirals both for COVID and antivirals for influenza. The antivirals do work well to help reduce your symptoms, but also help reduce your chance of complications from those things as well.
Clear. Tamiflu works against all these strains, so test positive. If you're positive, talk to your folks, your team, your provider, and let's get you on Tamiflu, because we do know that is a marked difference in how things go. Jessica, we're back. How about that?
We are back.
I know, we're all back. Here we go. The viruses are back. I promised myself I was done with that stuff. I was done with this with the community, and yet that's that song. Here we go again, on the road again with my buddies here doing this. Let's get to some questions from reporters in the communities. What do you have out there?
Well, we have questions. That's why we brought you in this morning. So we have quite a few. So stick around, please do. So Brenda, I'm going to start with Brenda. She says, I had flu A over a month ago and still have a nighttime cough and trouble taking a deep breath. How long might these flu symptoms last?
Yeah, that's a great question. And probably what you're dealing with is very common in different viral illnesses. It can be true with rhinovirus and metapneumovirus and all sorts of them, but it's very prevalent with influenza. There are two reasons to have a cough, or more than two, but a couple of strong reasons about why you have a cough after influenza. One is during a viral infection, your body's host defenses rev up, and part of what happens is your cough reflex really gets hyper-tuned. So that cough reflex turns up. Little things like going from inside to outside where it's colder, or changing like if you go to drink a cup of cold water or hot water, little things, talking too much, will aggravate those cough receptors, and you'll just start coughing. And that will calm down over time. It can take 4 to 8 weeks for that to happen. The second thing that can occur is you can get inflammation around your airway, and we call that bronchiolitis. And that bronchiolitis, that inflammation around your airway, is an irritant, and it will cause you to cough, and you can even be a little bit short of breath with it. If it's just a cough receptor thing, it's unpleasant to have to cough that much, and you can try some different cough suppressants. It's not going to hurt you to do that. And more importantly, you're usually not short of breath with that. If it's bronchiolitis, you might have some of that. You might even wheeze a little. And if you're an asthmatic or you have chronic obstructive lung disease with emphysema or heart failure, et cetera, be sure you're in touch with your doctor about that, because there are some things we can do to help with the bronchiolitis. It doesn't cure it. It can help in a decent percentage of patients. So we would want to know that. The good news is that this will go away. It is an irritant. It can be really uncomfortable. There are some things that can help it, and time is your best ally.
Gene wants to know, how likely is the flu to turn into pneumonia? He says he has several relatives that this has happened to.
Yeah, very common actually, and unfortunately, Hawkeye, when we look at mortality from influenza, that connection between flu and pneumonia is often the link to having a bad outcome. Talk to us a little bit about that.
Yeah, and I wanted to add to your last answer this exact point. I think you're exactly right. What you were just describing in that first question is what we have, that post-viral cough, and that can last 2, 3, 4 weeks or longer, just as you explained very well. The other entity that now we are being asked about is something entirely different. This occurs prior to that 2, 3, 4 week period in most cases. And this is what we see, unfortunately, with influenza more than other viruses like COVID or RSV, is the predilection or the risk of getting a secondary bacterial pneumonia. Now, what happens is you have influenza, you may take Tamiflu, you may start feeling better, and then 3, 4, 5, 6 days later, you start feeling worse with new high fever, new cough, new maybe chest pain. At that point in time, that can be very dangerous, and those are the main hallmarks and the symptoms of a secondary bacterial pneumonia, most often caused by either Staph aureus or Strep pneumoniae, are the two most common bacteria. So that is vitally important. So if you do have influenza and you're feeling bad and you get treated and you start feeling better, and then several days later you now have high fever or are feeling worse, it would be recommended to seek a healthcare provider to get evaluated to make sure you don't have a secondary bacterial pneumonia.
Just to follow up on that, in your situation, you mentioned a moment ago that we don't want patients who are sick to have a procedure or surgery, because we know we cause more complications. Talk to us a little bit about what some of those are and reinforce that message. Don't try to hide being sick.
Yeah, absolutely not. When you think about somebody having, you mentioned these things, bronchiolitis or even post-viral syndromes, or even, when you're actively sick, of course, you want to go to general anesthesia. That's a stress on your body. Just putting somebody to sleep and not even doing a case and waking them up is a significant stress on their heart, their lungs, your entire body. So when you do that, when we talk about intubating and putting somebody on ventilation, positive pressure ventilation, that causes trauma on your lungs. Most of the time, it's very minimal trauma, but if you're already set up with inflammation or something actively going on, it can be tremendously worse. So when someone is, a healthy 20-year-old and they do that, that'd probably be okay, but they might have a little bit rocky or recovery area. But when you talk about somebody that has other things like COPD, heart failure, diabetes, anything else, and you put somebody that's sick under general anesthesia, it can be much worse of an outcome. Higher infection rates, higher chance of an increased length of stay in the hospital, in the ICU, et cetera, et cetera. So it's very important that it's best for you to postpone that if you are even mildly sick.
Yeah, I think that's exactly right. And it reminds us to say that This year, there are already 5,000 deaths from influenza nationwide. Last year at this time, and last year was a severe outbreak of influenza, we were at 2,700. 5,000 is really high. It's like one of the higher levels we've seen in deaths at this point from influenza. So take it seriously. Remember, the pillars protect you. Get vaccinated. And if you're sick, test so that you can get on Tamiflu. Jill.
Yes. Okay. Priscilla says, I was vaccinated. Listen to this. She was vaccinated, got flu A, then bronchitis, then shingles, if you can imagine how awful. She said she felt like she was dying. This flu A was horrible, she says. She said she's without the vaccine, she thinks she wouldn't even be here. She wants to know, is it possible to get flu A and flu B at the same time?
Hawkeye, you don't want to do that, but it's kind of like Fluvid, right? When people had influenza and COVID, this is you can get more than one strain. It's unusual, but you can do it.
Yeah. Yeah, absolutely. I think it's unusual to at the same time. Typically, as you said early when we opened this news conference, is, we have this singular strain that is really more dominant going around at this point in time. But you also said there's still time to get vaccinated for influenza. And this is because later on in the season, you can have those other viral strains which now will have a resurgence. A lot of time what we do see is a surge of flu A really early in the season, the respiratory viral season, and then later on there will be a surge of flu B. So I think that is very accurate. You can certainly get another strain of influenza later on in the year, later on in the season. That is why even if you've had influenza this year and have not been vaccinated, you can still get vaccinated. It would still be recommended to get vaccinated to help protect you from those other strains that may be circulating later on in the season.
Vera wants to know, what's the difference between the high-dose flu vaccine and the standard flu vaccine? She says our area didn't have high dose, so we went with the standard dose for some sort of protection.
Hawkeye, this has been changing for a few years because they've even changed a little bit about, to your point, is that the trivalent or quadrivalent vaccine, well, we can talk about that and talk about the differences in high-dose and low-dose vaccine. Actually, unless you've had a transplant, any dose is a good dose.
Yeah, I think that's the bottom line. Any dose is a good dose. We have been giving the high dose, which is just a larger amount of the killed flu viruses within that vaccine dose to help especially those people who are older, who weren't maybe as mounting as good of initial response to the vaccine, to help mount a better response as well. And data on that is changing. Certainly any dose is going to be better than no dose. But we do tend to give those high-dose vaccines to those elderly or maybe even our immunocompromised patients as well.
Jill wants to know a couple things. Can you get the flu twice? And does the flu make you does it make your blood pressure high?
Well, that's a great question. You can. Illness can make you feel poorly, which can raise your blood pressure, and influenza and other viruses can affect your autonomic system. Your autonomic system controls your blood pressure and your pulse and different parts of your body, and so all that can be affected. It's a little more unusual to have a high blood pressure than a low blood pressure, Hawk.
Yeah, I agree. I think certainly maybe during the acute phase, if you're not feeling good and you're having aches and pains, certainly you can have a higher blood pressure. I wouldn't imagine that is a sustained response even after recovering from influenza. But just to your point, too, you can have other autonomic changes as well.
And if you already have some autonomic instability, like people with post-concussion syndrome or other things, it can really affect you even a little bit more in that way. Jessica.
Ruth wants to know, does increasing fluids, Pedialyte, help throughout the flu season, even if you don't have any symptoms?
Yeah, I don't know about it as a prophylactic technique. Having good solid nutrition, getting rest, exercising, the things we would all do, a little chicken noodle soup, vitamin C, all that I think is good for your soul, but mostly taking good care of yourself is the way to manage your disease. And if you have a chronic disease like diabetes or like COPD or asthma or heart failure, make sure you're in tip-top shape so that if you do get sick, keep your blood sugars under really good control, make sure you're getting plenty of rest, Make sure you're using your inhalers correctly. If you do those things, then you have a little bit more protection against a serious influenza outbreak and how it might affect you.
And remember, right, so staying hydrated, very important, absolutely. But remember, some of these things like Pedialyte, they do have sugar-free, but they also have a lot of sugar in them.
They do.
So you got to be careful doing things like that, especially if you have diabetes or another issue going on.
I just have a few comments and then one last question. Neva says, I haven't watched in a while, but when I saw this was going to be about the flu, I just had to watch. So she says, thank you.
Yeah.
And then
really thank you, or oh my God, they're back.
They're back. They're back.
Like
you can't get, you just cannot. You can't shake these guys.
I'm back.
I'm back. Lisa said, thank you so much for this very informative and important program. And thank you for keeping us updated and safe. We appreciate you all. And then Ruth said, thanks for this live update. Time to mask again.
Yeah.
So anyway, just wanted to give a shout out to those viewers this morning. And then Alexis says, I got the flu and then pneumonia. Does that mean I'm immune to both?
I only wish that were true. The answer to that is no, unfortunately. You can get a different strain of influenza or any other virus, and actually what can happen is when you have been sick and your immune system has kind of been fighting a little bit, you're a little more vulnerable, and that's probably why you get pneumonia. And Hawkeye, what I can tell people is, and what I do all the time, when you're sick, take good care of yourself, then hydrate, right fluids, and get some rest, and make sure you're eating, healthy, trying to have healthy dietary habits. Anything you want to add to that, sir?
I think that's spot on.
All right. So I don't know if there's any reporters on the team's call. I'm just going to ask, if you do have any questions, please say your name, your media organization. Lines are open. All right. I want to thank everyone for tuning in and listening today. We're sorry we have to be back doing this, but we also know that we think it's a shared responsibility for all of us to make sure you know where things are in our community and what you can do to keep yourself safe, help keeping our patients safe while we work to keep everyone safe. Hawkeye, final thoughts?
I think going back to the basics, be updated on your vaccines. If you haven't received influenza vaccine, you can still get it. There still is time. We still have a few months of respiratory viral season. Those pillars of infection prevention will help reduce your chance of infection. Frequent hand washing, keep your hands out of your eyes, your nose, your mouth. Wear a mask if you don't feel safe. Please stay home if you're able to, if you are sick. If you are sick and you do have to go out, please wear a mask. That will help decrease the amount of viral particles that are spread wherever you're at. Those are basic things everybody can do, and just as you said, take good care of yourself with nutrition, sleep, hydration. All of those things will help keep you well also.
All right. Thank you, sir. And always a pleasure to be back with you, Hawk. Dr. Coomer.
Well, yeah, all I have to say, take care of yourself. I think, we're back. We're talking about these things. We're talking about the basics. This is not a political thing. I know that lots of people out there like to politicize masks or vaccines. That's not what this is. This is about take care of yourself, take care of your community, do the basics, but we're here for you. So let us know if we can help you.
Yeah, right on. Well done. Both of you guys, well said. You know what? First of all, thanks again to any media that are here today. You clearly play an important role in helping keeping our community safe, getting the word out, and reminding folks to take precautions and take care of themselves. We're really proud to be part of the Kansas City metropolitan area and the state of Kansas and Missouri, and we know how well you responded. The last time there wasn't a significant public health risk, and we want to know that we're here to help. Our message today is really rooted in making sure you remember the rules of infection prevention and control, those pillars. As I said, they will keep you safe every day and every day going forward. Know them, follow them. Number two, don't forget that vaccination is not the enemy. I don't know why we've had to try to politicize something that's been around for over 50 years, but whatever, we did. And what I want to make sure you hear from us clearly is vaccination is safe. Vaccines are not your enemy, and they do keep you safe. And we know, just as we knew in COVID, the rate of death, if you haven't been vaccinated, the rate of death with influenza if you're not vaccinated, is markedly higher than when you are. And this is a significant influenza outbreak because we are so packed. We've got lots of patients in the emergency room that don't have a bed because we've got about 2.5 hospital units full of viral illness patients taking up those beds. The only way to fix that is for people to make sure they follow the rules of infection prevention and control. So again, we need your help. So stay safe. We'll continue our updates. You know, we were around this once before. We're back again. What I will say to you is what I said in the past. We want you to live long and prosper, but what we're going to do is make sure we tell you the truth without hyperbole. We give you the information you need to make your decision. And we try to help keep you safe. And to your excellent point, we're here to take care of you. And the best way for us to take care of you is for you to take care of yourself and our staff to take care of you too, and keeping each other safe so that we can get through this darn thing again. I don't think this is another replay of COVID. I think it's going to come and go. It's influenza. But it is serious right now. We want you to understand that so you can stay safe. Stay tuned for All Things Heart next with Alexis Del Cid. And until we meet again, remember, those pillars of infection control, that is good news. We'll see you soon.
I'm Alexis Del Cid, and I hope you're all having a wonderful start to 2026. Our team is taking this month to gather phenomenal news stories and topics for our next season of All Things Heart, beginning the first Thursday of February. And we already have some great patients lined up for you, like this Alaska man, Bart Rudolph, who chose to fly from Alaska to the University of Kansas Health System for his open heart surgery because there was no place he trusted more. And then Ryan Azuz, a young man living with an incurable disease who's joined his second clinical trial to help find a cure that could help others in the future. We are excited for what's to come. Until then, please enjoy this encore presentation.
I've said it once and I'll probably get it tattooed on me, you know, man plans and God laughs.
Robert Frias's care team kept his failing heart working for months, waiting for this.
Just know I believe in every single one of you. And thank you for showing up for work today.
Team on three. 1, 2, 3. Team.
This gift of life from a young girl.
You're the love to my heart, from Caitlin to my love.
Willing to give up her heart in death to save a life.
Strong as a bull.
That's right, baby, yeah.
Welcome to Choices, Hope, and Science. I'm Jessica Lovell. We are joining you from the Dolph C. Simons Jr. Family Broadcast Studio. Today, we follow Robert Frias's journey to a new heart. Team is a word you will hear a lot. Alexis Del Cid reports Robert found a strong team here at the University of Kansas Health System. Now, we do want to warn you that this story does contain graphic transplant video. Alexis?
Jess, Robert is a remarkable person and patient. Who among us would have the presence of mind to lead their surgery team on a chair from the operating table moments before their heart transplant? Robert would, and he did. Over the next half hour, you will witness more remarkable moments, including this one, the moment the surgeon places the donor heart into Robert's chest. But getting here, that was quite a ride.
All right, I'm gonna listen to your heart.
All right.
I've never heard an LVAD.
Okay.
It's not often you meet someone whose heartbeat sounds like this.
Can you hear it?
It sounds like a techno.
Yeah.
That's because Robert Frias doesn't really have a heartbeat, or a pulse for that matter.
If I go like this, they don't get a pulse.
He does have a pretty good sense of humor about the LVAD device keeping him alive.
I have a battery pack here. This is my control unit. The batteries, bunged. James Butt, locked and loaded. My dad was like, You're an adult now. I'm like, I know, still, it's fun.
On this day, he takes us on a tour of Central States Medical Supply,
This is our medial pivot knee.
where he's happily back to work as a sales rep,
4-corner, tri-corner plates.
supplying hospitals with all of their orthopedic tools for surgeries.
Man, I look forward to cardiac rehab now. I look so forward to just spending time with my daughter, my son, and being a part of life now.
The trouble began in 2014 when doctors at another hospital diagnosed Robert with congestive heart failure and implanted a defibrillator in his chest. After that, Robert says he thought he was fine. But a decade later, at a routine doctor's appointment in May of 2024, Robert blacked out. When he came to, he was in the hospital.
And then they came to me and said, we need to transfer you to KU. You're end-stage heart failure and you need a transplant.
But it turned out Robert was too sick for a transplant. They didn't think he'd survive it.
Being so sick as I was, they decided to go with the LVAD.
So the guy who'd happily observed thousands of orthopedic surgeries throughout his career was about to be the guy on the table undergoing open heart surgery.
I tell everybody I've not felt this good since my 20s. Honest to God.
And Robert's cardiologist, Dr. Hirik Shah, is here in studio with us today, along with his cardiac thoracic surgeon, Dr. Tyler Zorn, and Dr. Matthew Danter across from me, the surgical director of cardiac transplantation and mechanical circulatory support. Gentlemen, so glad to have you here with us today. Robert joins us virtually with us. Robert, you have been on such an amazing medical journey that we are going to share over the next half hour. But tell us, what is the one thing that stands out the most about your health post-transplant?
How I feel. I've said it before and I'll say it again. I feel like I'm in my 20s again. The amount of energy I have every day is just incredible. I mean, it is a truly, my life has been changed, honestly.
Dr. Shah, we're going to get to Robert's transplant here in just a moment. But this all started with heart failure and an LVAD, a mechanical device that is often called a bridge to transplant. How did that help him work towards that transplant?
Mr. Frias, he came in incredibly sick in our intensive care unit. All of us, took care of him. And an LVAD, left ventricular assist device, is a device that's able to be implanted into the heart by the work of our surgeons and able to take over the function of the left side of the heart. And for patients who come in incredibly sick and don't have a lot of time, because in transplant we have to wait for the right match. We have to wait for the right, match that will work for that particular patient. For patients who might not have enough time, the LVAD is an excellent therapy that allows us to essentially normalize their cardiac function, allow their organs to get adequate blood flow, basically make the patient healthier, and then they'll be in a much better place to get a heart transplant. When you're kind of walking into your heart transplant, it's going to be a much better outcome than going in incredibly sick, kind of getting wheeled into the ICU.
Well, let's talk about time, because time is key here. And Dr. Zorn, how long can someone stay on that LVAD before then requiring the heart transplant?
Yeah, so certainly the newer generation devices that we have now are much better equipped to support people long term, with much fewer complications. And so now we see, survival, out to 5 years pretty routinely in these patients if they're not transplant candidates. Hopefully they can, if they're bridge to transplant, can be transplanted sometime before then. But
Dr. Danner, Robert had to be sick enough to qualify, of course, for the transplant, but then healthy enough to get one. What makes someone too sick to get the transplant?
Well, typically there's some features that are acute and some that might be chronic. Acutely, if they're in multi-organ failure or have, sometimes we have people that are intubated and unconscious and we don't have time to sort out all of their neurologic status or even some of their social and family supports. Those are sometimes what keeps us from moving ahead initially. In terms of what in the chronic phase are more often we encounter people who have higher higher right-sided pressures, right ventricular problems, pulmonary problems, that are issues with their diabetic control, weight loss, these kind of things. So in a more chronic manner, we try and get these people who have these relative contraindications to moving forward with transplant into a much better state, so that, like Dr. Shah said, you come in for your transplant from home and you go out with a shorter length of stay and a better hospital course. That's the goal.
Dr. Shah, then what did Robert have to do while he was waiting for this transplant?
Yeah, I think it was to reverse some of the end organ function. I mean, he came in very, very sick. He was in our ICU for a very, very long time, and his post-LVAD course initially, took some time, but he was able to recover all his organs. His kidneys fully recovered, and when he was outpatient, he was able to walk, able to do everything that he was able to do before his diagnosis of heart failure. And so I think it was him building up his muscle mass, building up his stamina, building up his endurance, and all of the reasons why he couldn't do that was probably because of his heart was just so weak. And now that he has normal blood flow with the heart pump, he was able to get the body back to being a healthier body, back to his 20s, as he says. And then he was very ready for the heart transplant.
So you sent him home to do his homework.
Exactly. Send him home to do his homework, and he did it very, very well.
He was ready. He was ready for the call. Well, we had a chance to follow Robert through his entire journey, really, including the transplant surgery. Here again is Alexis Del Cid.
Jess, this is the video that makes us all smile because Robert was very present and very chatty right up until moments before he went under for the surgery. And again, a word of warning, Robert's story does include graphic surgery video.
Lay down in bed, and then all of a sudden, the phone rings.
From his hospital bed at the University of Kansas Health System,
I'm like, no.
Robert Frias is still processing the call he got at 1 a.m. from his transplant coordinator.
So I answered, I'm like, this is Robert, and it was Clinton, and he asked me very politely, are you still ready to do this? And I'm like, I absolutely am.
Sounds like a beat in a nightclub.
Yeah.
After living with his mechanical LVAD pump for 5 months, his coordinator Clinton told Robert that his new heart was on the way.
I remember I sat on the edge of my bed before I left. I was sitting there, I'm going, this is really happening.
Nobody expected he'd get the transplant call so soon.
It's a little surreal right now, but it's part of it, it's part of the journey.
A journey he just updated with a social media post to his loved ones.
I can't put into words right now how much all of you mean to me. But I just need to tell you that I love you all. And that, see you in a couple days.
Hi, buddy. I love you, man. Love you guys. I'll be right back.
Right before he goes under for the surgery, Robert, always the picture of positivity,
All right, bring it in.
has something to say to the team about to give him his new heart.
Just know I believe in every single one of you. And thank you for showing up for work today.
Yeah. Team on 3. 1, 2, 3. Team.
Robert, I've got to say, I've seen that video over and over again, and I never get tired of seeing it. Where did that come from? I mean, weren't you terrified?
I was more exhausted than I was scared. At that point, I'd been up for several hours, and, I actually gave that speech to my son's football team. I'd heard from another coach right before the game, and I remembered that. And that's always stuck with me. I remember telling them at halftime, and I'll tell you that we won. I don't remember, but it always seemed to rally the troops when I gave it, and that's kind of where I'm at. So.
Yeah, it was the winning chant. I like that. It was good. Of course, we know in a heart transplant, there is no living donor. Someone must be willing to give up their heart in death to save a life, and they have to make their wishes known. And when 15-year-old Kaylin Hartman from Texas died unexpectedly, her parents knew exactly what to do. In a letter, Kaylin's mother, Crystal, writes her daughter was full of life.
She started off life as a shy, quiet, and very demure kind of girl. But she came out of that with a flourish. She was an absolute card. Often I encouraged her to consider stand-up comedy as she knew how to deliver the laugh fest so well. She was an extremely studious student who excelled in all her subjects, and she made it a personal challenge to ace any test put before her. She was putting in the hard work of self-acceptance and teaching this to her classmates. I have notes from them expressing how she taught them to love the parts of them they hated. She was sassy, full of fire. She was not a sweet and quiet little angel, but rather more like an adamant but playful wood sprite that wore a very infectious but impish grin with mischievousness in her eyes. And frankly, in getting to know Robert, my thoughts are that they matched heart to heart.
Kaylin's father, William, traveled to Kansas City to meet Robert.
Mr. Hartman, how are you?
Wonderful to meet you. No, this is going to be a minute. Let me tell you right now, this is going to be a minute. You have no idea, sir.
I really appreciated you reaching out when you did. It was really great to hear from you, because when you go through this process, you don't know. You know they have a match, they have this and that, but you don't know if it's successful. You don't know if they made it in time to, you know, if they could use, you know. And the fact of knowing, right, that especially when it came to my daughter's heart, which was, you know, that it was successful. And what you wrote me really was a gift. And so I really thank you that that you took the time to do that, right?
William says his daughter knew how to love fiercely. He got a chance to hear her heartbeat again.
Strong as a bull.
That's right, baby, yeah.
Robert, tell us, what was it like meeting William?
It was amazing. I mean, it really was. I mean, to meet the man who made the decision to give me life, I'll be forever grateful. And it was emotional. It was a meeting that I'll never forget for the rest of my life. And I made a good friend, to be honest with you.
And your father went with you to meet William, and he gave you some advice on how to get through some of those low points. Can you tell us about that advice?
So when he was in the hospital previous to this, we'd always had this little saying to each other. And I'd always look at him right before I left. And I said, well, Dad, I said, you be strong and I'll be strong. And I never thought those words would ever come back to me until the day I was going back for my LVAD. And my dad looked at me and grabbed my hand and said, hey, remember what we say? And I go, what was that? And he goes, you be strong and I'll be strong. And I said, give it to me, let's go. I was ready to roll.
Good advice, good advice. Dr. Zorn, according to Kaylin's parents, she was born with a hole in her heart. Her parents also shared that she died from an allergic reaction. What do you have to take into consideration when accepting a donor heart?
Well, we look at everything with regards to the quality of the heart, the quality of the donor, what the heart looks like under certain imaging mode.
Heart.
Yeah, it's when I think about what leads to good outcomes after a heart transplant, I think there's two factors. There's one is the recipient factor, that's Robert's factor, and then there's the donor factor. And Robert was very healthy going into that transplant. With his LVAD, he was obviously, you saw videos of him talking and working and all of those things, and so that played a big role in his recovery. And then, like Dr. Zorn said, we look at a lot of things in the heart to make sure it's an adequate donor and make sure the donor is going to do what it needs to do to support the recipient. And many things we look at is age of the donor, and we know that, you know, unfortunately, the younger the donors, the hearts don't have the stresses that patients who are a little bit older, you know, have with diabetes, coronary artery disease, substance use, and things like that. So I think it was kind of a very good match in the sense that he was very healthy. The donor heart was a very good match for him, and I think that's why we see the outcome that we see today, and why he's doing so well is that it kind of checked all the boxes.
Okay, our favorite part of the show is our community questions, so I want to get to some of those. And these are the top questions we got for heart transplant. And Dr. Dander, I want to ask you, Angie wants to know, does anything have to be done to the donor heart before transplanting it?
Well, you know, as you're probably aware, there's a whole other team of doctors and specialists that are working at the donor site to coordinate all of the multiple organs that are typically procured. The heart itself is procured and removed in a very standard way, and then when it arrives back to the recipient hospital, it's inspected for any surgical trauma or any congenital abnormalities, which we can typically fix, most of which we would know up front, but at times there might be a small hole in the heart that we suture together, which is pretty, it's about 25% of the population has a probe patient. But other than that, we basically rely on the heart's own automaticity or its own intrinsic heartbeat to start again and to basically take over the role of the circulation once we take the clamp off.
So Jill asked, is the heart still beating when you transplant it?
No, it's typically been made inert by fluids that we give, not unlike when we put a heart to sleep for a conventional heart surgery, and then it's put in ice for the duration of the transport period. So what really starts the heart up again is when we reperfuse their own coronary arteries and when we warm up the organ. Sometimes we also have to externally pace the heart in order to give it an adequate rhythm to support the circulation. But most of the time, the heart starts up on its own. The sinking feelings as the surgeons is when the heart doesn't start up on its own, then we have to start making other decisions and other arrangements.
Dr. Zorn, when you removed Robert's heart, the LVAD was still attached. The heart was still beating. Becca wants to know, how long does a heart beat after it's removed?
I don't know. Sometimes it's beating when it comes out of the chest after you explant it. You know, sometimes it's not, but sometimes it can sit there for a minute or two. It's pretty wild to see a heart that's outside of the human body still beating, but it's what Dr. Danter says. These hearts, they want to keep going, and that's why when you plug them in and you restore blood flow, most of the time they'll just start up on their own.
I know you do this every day. We're just fascinated by the video and hearing your stories, so it's so interesting. Eric asked Dr. Shaw, will the heart transplant recipients always need to be on immunosuppressant drugs?
For now, the answer is yes. We do know the risk of rejection is the highest in the first 6 months to the first year of transplant. What we do is very protocolized, is that we reduce the amount of immunosuppression that we give our patients as they get further away from their transplant date. And so the side effects for immunosuppression hopefully get lessened over time. But right now, we do have immunosuppression lifelong for patients.
And David wants to know, how long does a heart transplant extend a life? And how did you have that conversation with Robert?
Yeah, when I talk to patients about, how long it's hard because we talk about medians. That means, the median average survival for a heart transplant is 12 to 14 years. But that means 50% of people live longer than 14 years. And I think that's kind of how I view it to patients. If we take care of this heart, we have a good chance to give you a decade plus of life with this heart transplant. And usually with the condition they're coming in with end-stage heart failure, that's way longer than they would be without heart transplant as an option.
Robert, I know you've been so grateful to the team here. Is there any message that you want to share with Kaylin's family and parents?
Give me a second. Thank you. Thank you so much for having the wherewithal to, at such an incredibly difficult time, to think outside the box and be a hero to numerous people. including myself, and I will forever be grateful for that decision. I will forever be, there's not a day that goes by I don't think of Caitlin or their family. That I'm truly blessed beyond words to have them, to know them, and to have this opportunity to live life. It is, to them, I love you. Bottom line, I love you guys more than you'll ever know.
And what message do you have to people about organ donation? Just about educating themselves and learning more about becoming one and talking to their families about it.
Take the awkwardness off of it. Have that conversation. Summer's coming up, families getting together. Do your homework, do your research, be a hero. Be an organ donor, save a life is really what you're doing. But make sure you express that to the wishes of your family, and that make sure it's known to everyone that you love, and that if God forbid something should happen, these are my wishes. And the old adage, we can't take it with us, but we can help another human being, which I think is innate in all of us. Be that person.
And I just noticed, Robert, the pin on your shirt that you carry with you.
I wear it all the time. I wear it every jacket, every shirt I have. It's a picture of her at the pool. Sorry, wrong one. But yeah, it's her mom's favorite, and I had a button made just so I can just look at it every day and be grateful that I'm here, and try to live the life that I'm supposed to because of her.
Dr. Danter, just a final thought. What do you want folks to know?
Well, I echo what Robert says about being an organ donor, and I also think it's hard not to be romantic about transplant, but there is the other side of that, and the tremendous gift that the families of donors and the donors themselves are able to give to people is something that I can assure you none of us take for granted. And it's absolutely certain, and it's absolutely true that the gifts that come from that are some of the most important that we encounter.
Dr. Zorn?
I mean, it's just what an incredible journey to see what Robert has gone through, from the life he was living before to his bridge with the LVAD to a transplant that was the gift of a family that was went through a terrible circumstance. But to see the outcome on the other side and to see what good Robert is doing with his transplant should be motivating to us all, and it's such a wonderful story to hear.
Dr. Shaw?
Yeah, I think they both said it very, very well. I think his journey has been incredible. I remember when I first met him in the ICU, he was incredibly, incredibly ill, and to see him now and still honor the donor's family as well as he's doing now, I think, he's a very good human being, and I mean, these stories are the reason why we come to work every day. So.
Well, Robert, we want to give you the final word here. What do you want people to know about heart transplant?
It's a life-changing event, obviously, but I would encourage people to do their research, look into it. Know this, that my life is 100% better. And I can tell you last year at this time, exactly at this time, because I went into the hospital March 15th, that I was a mess. And when I say that, I don't say it lightly. I was gaining weight, water weight by the day. It was, I was sleeping 90% of my day away. I was trying to motivate myself just to get out of a car and to walk up steps. And today, honest to God, the little things like that, walking up stairwells, walking down a hallway without stopping 3 or 4 times to grab the railing and just kind of pretend to check my phone while I catch my breath. It's the little things like that that add up to the bigger things, like what's going to happen next in my life. But I can't give you this, but until after you have the surgery, then you'll realize there is a better life for you, and I'm living proof of that, because I wouldn't be sitting right here, and I say this with all sincerity, without those three gentlemen to your right, and for everybody at KU for doing this to me. I mean, this is, I always said this once, none of this you see here is because of me. It's because of everyone at that hospital, at the University of Kansas Hospital. That's the reason I sit here before you.
Well, we are so grateful to you for sharing your story with us here today. Robert, be well. Thank you.
Thank you. Thank you.
Well, thank you to all of our guests for being with us today. It was such an important story to share.